Okay, so does everybody know what a Watts 3D brush is, or when you would use it? Is there any confusion on it? Well, I'll just give you a brief summary. So it's used adjunctively with forceps biopsies to screen and surveillance known and suspected Barrett's and dysplasia. Quick little study, we did last year with 24,000 patients. 1,300 of those that were detected with Barrett's, 46% alone were just from Watts. Forceps missed over 50%. And so then, same with dysplasia, 240 were diagnosed, 45% alone were just from Watts alone. And then, so as far as the technique is, we have 2 brushes, and then we also have 2 sample tubes. One is bigger, one is smaller. With the brushing technique, if the physician decides to use it after doing forceps biopsies, and a lot of the times it's spontaneous, you don't really know if the patient has Barrett's or whatnot, but sometimes you can plan it ahead. But let's figure that it's spontaneous, doctor decides to use it. He's gonna stick this brush down the endoscope, and then once it's time, you shove it out, the brush out, and it's not, the brushes are somewhat hard to really collect the amount of tissue needed. We collect about 90 to 95% of tissue in comparison to forceps, which is 5 to 10. So about 1 out of every 5 patients that get diagnosed with Barrett's are going home with that diagnosis. But once you get this into the endoscope, the doctor's going to say, I'm ready to brush. And so there's a few techniques. You can keep it out and then just go up and down. What some people do is in and out, but what I like to just suggest is just keep it out, go up and down 360 circumferential. About 1 minute, 30 seconds, the doctor should tell you when it's time to pull it out. He should have a good understanding of how much tissue is on the sample. We have a little comparison. It might be hard to see it on the video, but for everyone here, that's the before and that's the after. Almost every brushel has a little piece of tissue on it. So then once you're done with that, you slide it back into the scope, or into the tube, pull it up the endoscope, and then you're going to come to the tall tube first. You're going to stick the brush back out, cut it in. And if y'all ever need cutters or things like that, I have those. I'll be glad to give them to you guys. Once that is done, you're going to seal it up. You're going to stick a patient sticker on there. That's done. And so now you're ready for the second brush. And then you're going to do the same technique, stick it through the endoscope, pull out the brush, 360 circumferential, about 1 minute. So in total it's about 2 minutes extra. Could be 1 minute, depending on the process, depending on how quick you can get that tissue. After that, you go back to the small tube, cut it into the small tube. And then you put a patient sticker on. So that's 2 patient stickers already. And in regards to the TRF form, do the nurses or techs usually fill that out? Just for reference, this is what the TRF form is.
I'm going to say nurse because we haven't filled that out before.
Okay,
So do the nurses.
Let's do nurses here. So techs, most likely we're helping with the cutting and whatnot.
Right.
So now we're on the nurses. You put 2 patient stickers on each bottle. You have 1 patient sticker left. You need to go in with 3. Stick it right on the top. Nice and easy. You don't have to fill out anything right there. Doctor just has to sign the initial, what he did it for. Down here, whether you use 1 Watts kit or 2 Watts kits. You use 1 Watts kit. This is all 1 for segments shorter than 3 centimeters. Barrett segments shorter than 3 centimeters. Anything longer, 3 or greater, you would use 2. But and then if you do use 2, you check. You're most likely just going to use 1. So check the top box. On the back, there's a ton of CPT codes. On the cheat sheets that we have in the room, we have the highlighted CPT codes on the back that might be related to when you would use a Watts kit. From there, all you have to do is circle it. Don't worry about filling the CPT code part out. And then from there, that's pretty much it. Let me talk about the billing side of it really quick. So in the packets, we also have a little billing information sheet. This is for the customer. We would like to do it pre-op to, ensure the patient knows everything that we're about to do. But like I said, it's spontaneous. So most of the time this is post-op, and you're giving this to them. If they receive anything in the mail, it's an explanation of benefits. It's not a bill. We have a cost reduction program that they can call. We can reduce it all the way, if not most of the way. And we do have numbers to back that up. I gave Diane a few contacts specifically related to billing. We take that with pride because that is a little kickback sometimes. So if y'all ever do anything with billing, come to me. Is there any questions on the process? It's rather simple, 3-step process: tall tube, small tube, 3 patient stickers. We good?
Good.
Perfect.
In the box, seal it.
And then, yes ma'am, great point. And so from there, the box, you could actually put up to 3 of these in here, I've heard people, or maybe even 4, I've heard people put the test in, but you can pile them up, and then from there, yes ma'am, go ahead and tape it, and then send it out.
Do the tubes need to go inside that bag or just go strictly in the box?
That's a good question. So we have the smaller bag within the big bag, and so once you're done with the tubes, big one first, small one, patient sticker, drop them in, roll it up, and then along with the patient face sheet and the TRF, all 3, bang.
Okay.
We good? Any questions?